Thank you for inviting me to speak with you today. Let's see if I can make this actually work. The arrows, okay. There we go. Okay, so given the relatively short amount of time, I thought I would discuss two topics at either end of the spectrum, talk a little bit about infants and early treatment and the viral reservoir, and then go to the other end and talk about perinatally infected adolescents and complications and transition to adult care. So starting with infants, how early must early treatment be? So we know that early treatment in the first 3 months of life significantly reduces morbidity and mortality. And the SHARE study that everyone's very familiar with showed a 75% reduction in mortality, 77% reduction in death and progression, with early treatment started at less than 12 weeks of age compared to deferred therapy. We've also learned that early treatment can restrict the proviral reservoir, and these are data from Debbie Prasad, currently in press, looking at 144 youth with perinatal infection who have been suppressed in the pediatric HIV AIDS cohort study. Median age of 14 years, median duration of treatment for 10 years, and she looked at the proviral reservoir by the age at which virologic control was achieved, and you can see clearly that for children under 1 year of age who achieved virologic control, their proviral load was significantly less than in children who achieved a virologic success at a later age. Interestingly, despite achieving very low viral reservoir, when immune activation markers were compared among children who had their first suppression at less than a year in blue, 1 to 5 years in pink, or greater than 5 years in green, when they compared that to HIV-exposed uninfected children in purple, you can see that their inflammation, immune activation markers remained elevated. And so early treatment, starting at less than a year, led to a smaller proviral reservoir, but it did not reverse immune activation. So one question is, did they not start early enough? So these are data on early treatment from Thailand on 15 children, all of whom started therapy at age less than 6 months and had viral suppression for 6 years. And you can see that integrated HIV DNA was very low, 17 copies per million cells, and 60% of these children had undetectable integrated RNA. And none of the children had 2 LTR circles, which is a sign of active replication. Thus, starting treatment at age less than 6 months results in a restricted viral reservoir and also resulted in a restricted immune response. 93% had no HIV-specific immune response, and 47% were negative on antibody. So looking at even earlier therapy, this study by Debbie Prasad looked at 17 infants who started treatment at a median of 8 weeks, and it looked at, again, proviral reservoir. And the red dots show you children who started treatment at less than 6 weeks, while the blue dot shows you children who started treatment at greater than 6 weeks. And you can see that there's a significantly lower reservoir size in infants who were treated before 6 weeks of age, and also the reservoir decayed during the first 2 years of life, although in most children it still remained detectable with a half-life of 11 months. So in this study by Catherine Luzuriaga, she looked at 4 infants with early treatment. Now this is now going to treatment as early as 2 weeks of age compared to children who started later. And you can see that the early treated children were suppressed for nearly 17 years, and they had undetectable plasma RNA, an even lower proviral load than in the Thai children. Only 1 child had replication-competent virus, and there was no HIV-specific immune response. And in these children, the proviral load continued to decline over time. The graph on the left shows you proviral load by age of the child, and you can see going from birth to 13 years, a significant decline. And the curves on the right-hand side are individual curves for the individual children, so you can see continued decay. Another indication of restriction of the reservoir and lack of viral replication is shown on this slide, which looks at Western blot antibody findings in these 4 early treated children compared to those children treated later, where you can see that their Western blot remained reactive despite being negative and virally suppressed for many years. So what about treatment starting at birth? We talked about less than a year, less than 6 months, less than 6 weeks. And, we had what we thought was very encouraging data on a potential functional cure. But we now know that this was viral remission as opposed to cure. But this doesn't mean that we've failed, and these are just some statements taken from the NIH press release that I wanted to highlight some specific comments. The fact that this child remained off of treatment for 2 years in the absence of any HIV-specific immune response is really unprecedented. So while early treatment didn't necessarily completely eliminate the reservoir, it considerably limited and averted the need for treatment over a considerable period. And actually, if we go back, the SHARE trial actually demonstrated this for us earlier. And in this SHARE trial took children diagnosed with HIV before 12 weeks, and they were randomized to either deferred treatment or immediate treatment for about a year, or immediate treatment for 2 years, and then stopping with resuming treatment if they had virologic rebound or clinical progression. And this slide shows you the proportion of children starting on continuous treatment. So in the deferred arm group, the median time to starting treatment was 20 weeks. In the arm that received treatment for a year and then stopped, the median time to restart was 33 weeks, and 19% of those children did not require a restart. And for those children treated the longest, the median time to restart was over a year, 70 weeks, with 32% not having to restart. And when you look at death, clinical events, and hospital admissions between the deferred and the immediate groups, despite the fact that the immediate groups stopped, the rate of death, clinical events, hospital admissions, and days in the hospital were significantly longer in the deferred arm, despite the fact that they actually received longer antiretroviral therapy. So this is very similar to the Mississippi baby and is consistent with early treatment potentially significantly restricting the viral reservoir, and that potentially a longer duration of treatment before interruption would allow a longer time off of therapy. So what have we learned? The early antiretroviral treatment studies in the Mississippi baby has shown us that there's a potential for a significant restriction, although not yet elimination, of the viral reservoir with very early treatment. There's a continuing decline in the reservoir over time, a loss of HIV-specific immune responses, and remission of HIV off of treatment. And there are many questions that remain, some of which I've listed here, and one of the most intriguing is whether one can use an immune-based therapy, vaccine or monoclonal antibody, to stimulate the HIV immune response and allow even more prolonged remission off of treatment. So then just moving very briefly to adolescents. So the number of new infections among children has decreased, but I want to remind you that our definition of elimination is still 40,000 infections each year. Whoops. And elimination does not mean that these young people are going away. The estimated number of children living with HIV in sub-Saharan Africa remains at nearly 2 million by 2020. HIV-infected children are now aging into adolescence. HIV has become a chronic disease with all its challenges, and newly recognized late complications are being detected with chronic HIV infection as well as a consequence of its therapies. And this just shows you a number of complications that have been seen in children, and you'll actually hear about a number of these during these presentations. A number of challenges exist, including disclosure, linkage and retention in care, accepting and adhering to therapy, mental health issues, but importantly, this is a high-risk group for HIV transmission, with 40 to 60% of adolescents engaging in unprotected sex. And this can be shown through these data from the FACTS study again, 377 youth interviewed regarding sexual activity. 28% were sexually active at initial and follow-up interviews. 67% of 18-year-olds had initiated sex, and you can see the mean age of sex was quite young, 13 years for males, 14 years for females, and this results in a new challenge, which is pregnancy in perinatally infected girls. And between 1998 and 2013, there have been 16 publications on 277 pregnancies in perinatally infected girls, most of these being unplanned. Elective termination was not uncommon, but repeat pregnancies were also not uncommon. Adverse pregnancy outcomes may be increased, but interestingly, mother-to-child transmission was uncommon, only 2%. And then we've got transition to adult care, and these are data from the UK looking at perinatally infected youth and mortality. And the main thing to notice here is that mortality was highest in those young children who then transitioned to adult care. And these youth have complex medical and psychosocial issues. 82% of these deaths were associated with poor adherence and advanced HIV disease. And I just bring to your attention that there is a special poster session discussion, and actually I believe right after this session there's a special session that Annette, I think you're doing on transition. So in summary, while we don't have a cure, very early treatment of infected neonates has a promise in significantly restricting the viral reservoir and inducing remission. The potential utility of stimulating the HIV-specific immune response in such children to prolong remission remains, I think, an important research area. But even with elimination of pediatric HIV, we're going to have millions of perinatally infected youth surviving into adolescence and young adulthood, and we need to address new challenges in such youth, including late complications, sexual activity, and transition to adult care. Thank you.